or full thickness rotator cuff tears, as well as and including biceps pathology. So the extrinsic theory is really that mechanical impingement or friction of the outlet itself onto the rotator cuff causes this issue. And Meyer in 1922 suggested that the contact between the greater tuberosity and the acromion was a cause for rotator cuff damage. And then later, Codman in 1932 suggested and elaborated that the process may be multifactorial and some sort of trauma or insult is needed to start this vicious cycle of inflammation that ultimately leads to tendon degeneration and tearing. And finally, Neer in 1972 described this chronic impingement theory, and that's what we have pictured here in this classic article. In this instance, impingement he defined on the tendinous portion of the rotator cuff by the coracoacromial ligament and the anterior 1/3 of the acromial, suggesting it's responsible for this characteristic syndrome of disability in the shoulder. The treatment of impingement was to remove the anterior edge and undersurface of the anterior part of the acromion. And he had several stages from edema, hemorrhage, to fibrosis, tendinitis, and bone spurs and tendon rupture. So ultimately, others have suggested, my senior colleague, Dr. McFarland, and others, that maybe it's perhaps more appropriate to suggest that rotator cuffs are really associated with certain acromial morphologies and spurring, but studies have not shown causation. And impingement should really be better referred to as rotator cuff disease, because that more accurately reflects the multifactorial nature of this problem. Intrinsic degeneration, on the other hand, of the tendon with age has also been shown to be a causative factor. So classic impingement syndrome or pain might be better referenced as anterolateral shoulder pain because of the variety of etiologies of pain in that region. So the intrinsic theory suggests that this degeneration causes some traumatic issue, leading to a weak supraspinatus that's unable to keep the head centered, extending to humeral head migration or abutment of the head against the acromion, which ultimately then leads to this acromial spur. So where is the truth? This rotator cuff pathology is likely a combination of both intrinsic and extrinsic factors, and each patient likely has a different amount of contribution of these factors and reflecting their genetics, their scapular morphology, and other environmental factors. So what other anatomic characteristics play a role? We know the Bigliani classification suggested flat, curved, or hooked types of acromions, but the evidence is a bit mixed with respect to their outcomes and their correlation. Ultrasound studies showing a high association with type 3 population, but there's poor inter-observer reliability when classifying type, as suggested by several other studies. So as we look at magnetic resonance imaging of these different types of morphologies of the acromion, this study out of South Korea looked at 29 patients with this hook type, and ultimately there was no difference in ASCS scores or constant scores in the hooked group, although the constant score was slightly lower, but not greater than the MCID. Acromial enthesopathy and rotator cuff tears have also been looked at in a cadaveric study, and they found no correlation between degenerative changes on the undersurface of the acromion and rotator cuff tears. And with 34 of 36 cadavers with partial cuff tears were really articular-sided, regardless of the spurring. So they thought more likely an intrinsic pattern. So the conclusion so far suggests the spur might be a consequence of the cuff dysfunction and not the cause, and the shape of the acromion may not be as important. So there's no agreement on classifying it anyway. So there has to be other factors. Rotator cuff is the only tendon in the body that is covered by bone, the acromion, and also is disproportionately torn. So if we consider the quadriceps rupture rate of 1.3%, patellar tendon less than 0.5%, triceps less than 2%, Achilles rupture even less likely at 5 in 100,000 people every year for an incidence. So population studies of rotator cuff tears, on the other hand, 8 to 23%, which is really high. So there must be something to do with this acromion and scapular morphology, but we're still figuring out what. So there have been many anatomic and evolutionary type studies suggesting the coracoglenoid angle may be different, or the size of the supraspinatus and the supraspinatus fossa have changed over time as we've evolved. So in an evolutionary sense, this study suggests that alterations in this morphology may not be responsible for some of the high numbers of cuff tears. However, other studies looking at different um, species, from chimpanzee here on the left to Homo sapiens on the right, show this variation in acromial coverage. So a larger deltoid, a wider acromion, and smaller supraspinatus can lead to increased superiorly directed forces, and that may have something to do with it. So we come up with these more modern evaluations of this coverage of the humeral head under the acromion, the acromial humeral index, and then more recently, as proposed by Gerber, the critical shoulder angle that takes into account glenoid inclination as well as lateral acromial overhang. And however, the position of the humeral head relative to the acromion was discussed prior to these concepts, and it's really the percent of humeral head coverage of the acromion. And they did find a correlation with rotator cuff tears. When you have greater coverage, a greater percent of the humeral head under the acromion, a much higher likelihood of a tear compared to less coverage. And we see these variations in pathology. A greater CSA correlates with cuff tears as the force vector is directed upward versus our osteoarthritis with the force vector directed more medially, as you can demonstrate here. So does scapular morphology affect the integrity of the rotator cuff? The studies are mixed, and it's quite confusing. This study by Pandey et al. Suggested there was no association with Bigliani type, and the acromial index and CSA were significantly different between the two groups. So the CSA and acromial index likely play an important role in patients that progress to full thickness tears and develop spurs. But again, causation is not clear. What about the clinical studies? So there aren't a great deal of studies, but this is a 2-year randomized control trial of 134 patients with exercises versus subacromial decompression. So both groups had significant improvement at 24 months, and there was no difference in the large majority of the outcome scores in pain. However, the subacromial decompression group did have quicker improvements, but also costed more money. And another multi-center trial with 3 groups, subacromial decompression, diagnostic scope, and no treatment, with only 6-month follow-up in the Oxford Shoulder Score, all groups were found to have improved with no difference between groups. However, if you look at the treatment assignments, many of them were did not remain in their assigned treatment group. So it makes it very difficult to interpret these studies. So is shoulder impingement syndrome and subacromial decompression, and it did not differ from diagnostic arthroscopy for shoulder pain at 24 months in this study published in 2018. So secondary analysis compared decompression to PT only, and it did do better, but not more than the minimal clinical important difference of 15. So in another study comparing subacromial decompression to therapy alone, again, no difference in cuff tears on ultrasound, but trended towards more tears in the PT group, which is concerning. Another trial, 2-year follow-up by Verma's group, looking at the use of subacromial decompression in the setting of arthroscopic repair. That's a little bit different question than what we're asked to evaluate with impingement. However, I think it's important when you look at the subgroup analysis, there was starting to be a trend towards significant re-tear rates higher in the group that did not get the acromioplasty. And another recent study showing post-op MRIs at 2 years showed no difference in morphology between healed and unhealed tears. So there's a lot of confusion about these angles and clinical results after. And the real question, what we're trying to get at, is can we surgically modify any morphologic characteristics? And we're only starting to get at this. Millet started to look at a cadaveric study showing it was possible without deltoid dehiscence to narrow that angle and decrease the humeral head coverage. And Gerber's study, this case series is interesting as it looked at 49 patients, and the actual clinical effect of a critical shoulder angle reduction showing that the post-op CSA is significantly larger in repairs that failed. So there was some benefit, and there is some intrigue here that this decompression can modify the natural history afterwards through surgical decompression. So this study is a radiographic follow-up of Dr. Verma's study long-term that didn't find any differences in CSA. So in conclusion, the recent clinical studies have concluded that acromioplasty does not offer many benefits, or it's mixed, but we have to keep in mind these studies are underpowered with short follow-up, with mixed interventions that people have transferred groups that they were assigned to, even in the randomized trial. So the results are very difficult to interpret, and they tend to the null hypothesis, meaning that all groups are similar. So the beneficial effects of the decompression are likely much more important over long periods of time, over lifetimes, decades, and we just don't have that kind of research available to us. But a well-done subacromial decompression is still an important part of the surgical treatment armamentarium that we have, in my opinion. And I think it's important to consider these factors, and they may, when we're still figuring out how to apply them to each individual patient, it's still a relatively novel concept about what aspects of scapular morphology are important. So what to do? The goals are obviously still remain to remove pain generators, remove extrinsic bone compression, bursa, the coracoacromial ligament. Maybe it promotes some additional biology when we're doing rotator cuff repair, the bleeding. Maybe there's some placebo effect and forced rehab. Patients are forced into this regimented rehab after surgery. While the evidence is low, it's very difficult to get high quality evidence. It is intriguing in my mind that the natural history over long terms does suggest some influence of the subacromial spurs. And I think the risk is quite low to do this. So I think the harm is low and limited. So in my opinion, there is still a role. We just still have to figure out exactly what that is. Thank you for your time.